RNA titer greater than 1,000 and whose CD4 cell count less than 250, then the liver disease progression decompensation risk will be higher. And currently, we have several effective regimens for the treatment of HCV in the HIV co-infected subject, including, again, the pangenotype sulfur-valproatovir, glycaprevir, piperantosvir, and elbasvir, grazoprevir. And if patient already liver decompensation, we can only use a sulfur-based regimen. And for patients with CKD stage 4 or 5, again, we may recommend glycaprevir, piperantosvir, and elbasvir, grazoprevir. And the main finding in the HIV co-infected subject is very simple. As for efficacy, the SVR rate similar to those with HCV monoinfection. So HIV co-infected subject is no longer difficult to treat population. And one very important clinical concern is, again, the drug-drug interaction with heart therapy for the underlying HCV infection. Recent trial published using sofosbuvir and valproatovir to treat HIV co-infected patients. Again, this is a pangenotype regimen. The treatment duration was 12 weeks. And underlying, patient may receive various heart therapy. And for efficacy, quite simple again, the SVR rate greater than 95%. And the SVR rate was noted across various genotypes and across various baseline conditions of the patient, including cirrhosis or not, treatment experience or naive, and different ethnicity. As for safety, actually current DA-based therapy, again, rare patient experience severe AE or due to AE leading to stopping the medication. Usually, the patient experience quite common constitutional symptoms using various DA regimen. Another study using glycaprevir and piperantosvir to treat HCV genotype 126 patient in HIV co-infected subject. Again, the treatment duration was 8 weeks for non-cirrhotic subject and 12 weeks for cirrhotic subject. SVR rate quite high, more than 89%. And again, rare patient experience SAE. And another, the safety profile, again, you can see that it's quite satisfactory. And another study published earlier using grazoprevir and elbasvir to treat HCV genotype 1-4 co-infected subject, the so-called CH study. Again, SVR rate was satisfactory. And one very important issue in addition to the drug-drug interaction is the reinfection of HCV in HIV co-infected subject. Recent population-based survey investigating the prevalence and the risk factor of HCV reinfection. And one very important factor to be found is the HIV co-infection. For some patients experience the risky behavior actually after the cure of the virus by DA, 1 year, 3 years, actually the risk of infection will increase gradually. And for some high-risk behavior population, the risk of reinfection can be higher than 10% after a 3-year follow-up. And in Taiwan, we also have some experience treating HCV in the HIV co-infected subject. This study conducted by Liu Zhenhua, my colleague, using valproatovir and sofosbuvir to treat HCV infection in patients with HIV co-infection, control group no HIV infection. And as you can see, the efficacy is quite high again, 100% achieved SVR. Only one patient experienced relapse after the end of the therapy. Drug-drug interaction are quite important for the HIV co-infected subject. So this table just summarizes various DDI to be concerned or avoided if the patient receives GP or Icrusa pangenotype regimen. And as for heart therapy, very important. Different DA would have a different heart regimen to be avoided. This table just briefly summarizes the commonly used heart to be avoided. Because HCV infection is quite convenient and effective in HIV confection, so the IDSA guidelines suggest in the era of potent HIV, patients with HIV-HCV confection actually are still at a higher risk of progressive liver disease. And this confected subject can be treated and retreated the same as a patient without HIV infection. And one issue to be concerned is the drug-drug interaction. And finally, I'll briefly go through the management of HCV for patients in the pregnancy setting. The principle is very simple. Treatment of HCV with DA during pregnancy and breastfeeding actually is currently not recommended because of lack of safety data. And a previous small study demonstrated exposure to ODA is likely to be altered because during pregnancy, the DA absorption metabolism will be changed after pregnancy. And animal studies show that most DA can cross the placenta and transfer into the breast milk. And this table just shows you the safety and PK of DA, various DA in pregnancy. You can see that actually, for the majority of DA, the concentration will be decreased because of the induction of the CYP3A4 enzyme and because of the change in the stomach pH. And for safety issue, actually, several regimens right now do not have a very solid safety data. And this table again just show you the safety, including the teratogenicity studies. Again, the DA can be transferred across the placenta and transferred into the breast milk. So because of the clinical request called by the WHO, for some patients, if they are urgently to be treated during the pregnancy, it is recommended maybe the treatment should be started at the end of the second or early third trimester. And of course, for the treatment of the HCV in pregnancy setting by using DA, maybe more studies are still needed regarding the safety issue of this clinical situation. So, Mr. Chairperson, ladies and gentlemen, based on this data, I would like to summarize. DA-based therapy currently is highly anticipated for all HCV-infected subjects, including the general population and some special population, for example, CKD and HIV co-infection. And for HIV positive subject, DI is a concern, and heart therapy should be checked before DA. And for pregnant women, the indication and selection of DA need to be studied further. According to current guideline, DA therapy may not be recommended due to a lack of safety data. I thank you for your attention.
Thank you very much, Professor. Now we come to the next speaker, Professor David Hanjoyo Mulyono. Prof. David is undergraduate from Faculty of Medicine, Airlangga University, Surabaya, Indonesia, and postgraduate from Department of Internal Medicine, Airlangga University, PhD program in Division of Immunology and Molecular Virology, Jinsei Medical University, Japan. Now, Professor Davis is a coordinator of Emerging Infectious Disease Unit, Eijkman Institute for Molecular Biology, Jakarta, Indonesia, Chief of Hepatitis Unit, Eijkman Institute for Molecular Biology, Jakarta, Indonesia, and member of National Working Group on Hepatitis. Prof. David will deliver the topic, the global burden of HCV infection in Eastern country and its impact treatment policy. Prof. David, time is yours. Please.
Good morning, ladies and gentlemen. Thank you very much for the moderators, and I thank the organizer for inviting me to give a talk at this symposium. Talking about East Asia, I refer to as this Asia-Pacific region, which is covered by Western Pacific region and also Southeast region of the WHO offices, including the Turkey, which is actually belongs to the Middle East, and